Hello, everyone. Happy evening. A very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good so that we can start with the today's marathon in radiology. Yes, I believe that it's all good. So we have some very, very important images, concepts in radiology that are must know before your exam. So we are going to quickly brush through those. And this is something that you should be revising one day before the exam as well, before your NEET PG exam. Yes. So just give me a quick thumbs up, everyone, so that I know that all of you are ready for the discussion. And yes, here it goes. So we have this first question here, which you might have seen on the Instagram handle as well. So yes, Raja, you would get the PDF on the Telegram group post this session. We would be sharing the PDFs on Telegram groups as well. So which of the following might have led to the given pathology that you see here? Is it the rupture of middle meningeal artery, rupture of aneurysm, hypertension, or the rupture of cortical bridging vein? So absolutely right. I could see that on Insta as well. Majority of you got this one right. So this is option B. That is the correct answer here is option B. That is rupture of aneurysm. Okay, so this one is rupture of aneurysm. Why? Because let's have a look at this image here. So what do we see here is this is a non-contrast CT. Okay, so this is a non-contrast CT, which is showing this white, that is hyperdense areas. White stands for hyper. So we see this hyperdense areas here. This is the hyperdense area. This is the blood in the fissures, right? The blood in the cistern, the blood in the perimesencephalic cistern. So all of this is the acute hemorrhage. What is hyperdense on non-contrast CT is acute hemorrhage. So what kind of hemorrhage is this? Now, when you see the blood in the CSF containing spaces, that is the sulcal spaces, the fissures, the cisterns, like you see here, then it is subarachnoid hemorrhage. Because what does the subarachnoid space contain? The subarachnoid space contains CSF, right? So what happens in subarachnoid hemorrhage? The CSF gets replaced by blood. So instead of the dark CSF, you would see the white blood like you are seeing here. Absolutely right. Like majority of you are saying, this is also called as the star of death. Right. So this one, the cistern here, it has this pentagon shape or the star shape. So that is called as star of death. So if I ask you the question that what is the most common cause of subarachnoid hemorrhage? Remember, the most common cause of subarachnoid hemorrhage overall is trauma. And if the question is what is the most common non-traumatic cause? What is the most common non-traumatic cause for subarachnoid hemorrhage? Then that one is berry aneurysm rupture. Okay, then it is berry aneurysm rupture. So berry aneurysms basically in the circle of Willis. That is why the answer here is rupture of aneurysm leading to subarachnoid hemorrhage. This was the question that was asked in NEET PG 22 as well. A direct question was rupture of berry aneurysm leads to which kind of hemorrhage? Right, the same concept, and the answer is subarachnoid hemorrhage. Now, next one is what will the patient present with? Subarachnoid hemorrhage ka patient will present with thunderclap headache. That is the worst headache of life. Okay, thunderclap headache. That is the worst headache of life. The next question is what is the first investigation that you would do in this patient? The first investigation would be non-contrast CT because for acute hemorrhage, it is non-contrast CT. Okay, for acute hemorrhage, it looks hyperdense. So non-contrast CT is the first investigation that we would do. What is the next investigation that you would like to do in this case? If on non-contrast CT, you see that there is subarachnoid hemorrhage, then we want to look for that which aneurysm has ruptured, right? So to look for the aneurysm, we would do CT angio. Okay, so the next investigation would be CT angio, basically to look for aneurysm, which aneurysm has ruptured. So for that, we would do a CT angio, right? Is this clear with everyone? So this is about subarachnoid hemorrhage. Let us quickly have a look at the other options also. Rupture of middle meningeal artery, that would lead to EDH, extradural hemorrhage, that has biconvex shape. Remember, EDH is idly shape, right? Hypertension. Hypertension is a cause of intraparenchymal hemorrhage, most common site being putamen. Okay, most common site being putamen. Rupture of cortical bridging vein, it leads to SDH. S for sickle shape. Okay, that is sickle shape or crescent shape or concavo-convex shape. Right, so those are the various hemorrhages. Recent FMGE exam also had a question on EDH. So these acute brain hemorrhages, EDH, SDH, SAH, intraparenchymal hemorrhage are very, very important and we should know how to identify them. Right. So have a look at this next image and tell me what are you seeing in this image here. What are we seeing in this image here? So if you have a look at this image very carefully, this is the CT scan with the white bone. And this is the hyperdense sylvian fissure here, the area of sylvian fissure, right? That is showing, this is showing blood. So again, this is subarachnoid hemorrhage. This investigation is CT angio, right? Where we are seeing the white blood vessels. All these are the blood vessels white. And this is the aneurysm that we are seeing here, right? So this is where we are seeing the aneurysm in CT angio, right? So that is the aneurysm which we are seeing here. Okay, so subarachnoid hemorrhage and the CT angio showing the aneurysm. Going on to the next image here showing the various types of hemorrhages. So what do we have? STH is sickle shape, right? That is crescent shape. Then we have EDH, which is biconvex shape, idly shape. And SAH is in the sulcal spaces, right? SAH is in the sulcal spaces. And intraparenchymal hemorrhage is right in the center of the brain, surrounded by brain, right? So these are the various hemorrhages that we have. Going on to the next image here, a quick revision of the images. So we have had a discussion. So this one here, which is the biconvex shape, idly shape, this is EDH. Is this right EDH or is this left EDH? Remember, this is the right side of the patient, your left, but the patient's right side. Okay, so this is right EDH that we are seeing, right acute EDH. It is hyperdense. This one here, which is sickle shape or crescent shape, this is SDH. This is your right side. That means the patient's left side. This is left acute SDH. Okay, this is left acute SDH that we have. So one of these images frequently asked in the exam. All right, let's go on to the next question now. What do you think is the answer to this one? A delayed IVU of a patient is shown. What is the most likely diagnosis in this patient? Is it Staghorn calculus? Is it putty kidney? Is it PUJ obstruction? Or is it the renal cyst? So we see a lot of confusion here in these options and the answers that I see. Majority of you are getting this right. But so this is also a recently asked question. Now this is a delayed IVU that is already mentioned here. Even if it was not mentioned, by looking at the image, we can identify that this is IVU. This is not a plain radiograph because you can see the contrast in this kidney as well, and you can see the ureter on the right side. So we can see the right pelvic-calyceal system and we can see the right ureter. What do we see on the left side? This is the left pelvic-calyceal system which is dilated. After this point, we are not seeing the ureter here, right? The ureter is not visualized even in the delayed IVU image. It's already mentioned that this is the delayed IVU image. So we should have seen the ureter. That means that there is some obstruction here. It is not allowing the contrast to go into the ureter, right? So that is why this is PUJ obstruction. Okay, this is the case of PUJ obstruction. A delayed IVU image not showing the ureter opacification is the PUJ obstruction. Why is this not VUR? Anybody, why is this not vesico-ureteric reflux? Now understand the concept here. When I say it's vesico-ureteric reflux, first of all, the investigation that we need to demonstrate the reflux is the contracting bladder wala investigation, that is MCU. When the bladder contracts, then we would see the reflux going into the ureter and the kidney. So first the reflux goes into the ureter and then it goes into the kidney. So first it has to be MCU to demonstrate the reflux. Second, first is the ureter opacification, then comes the kidney opacification, right? So this one is not, okay, this one is not the VUR. Why is this not Staghorn calculus? Staghorn calculus you would see on a plain radiograph itself, right? You would see on a plain radiograph. So that is why before doing IVP in any patient, first thing that we do is a plain radiograph, because we need to know that any opacification that we are seeing in IVU, is this the contrast or is it the calculus that was already present? So always do a plain radiograph before doing a IVP. You would see the calcification in the plain radiograph itself. Let me show you the image here. So look at this image. Now this first image that you are seeing here, this is not a IVU, right? Because you are not seeing the kidney, the ureter, the bladder here on the other side. If it was IVU, you would see it on the other side as well. So this is a plain radiograph. Okay, this is a plain KUB X-ray. And in the plain KUB X-ray, you are seeing this white area, that is calcification. So this one is basically the Staghorn calculus. Okay, this one is basically Staghorn calculus that we are seeing. So Staghorn calculus would be on a plain radiograph. What do you think is the next image showing now? The next image is showing the renal calcification that we are seeing, the renal parenchymal calcification that we are seeing there on a plain radiograph. So this is what is putty kidney. Okay, this is what is putty kidney, which is seen in tuberculosis, and we see autonephrectomy, right? The kidney becomes non-functioning. It is like autonephrectomy that we see in TB, right? That's the putty kidney. So all of these images have been asked in the recent exams. So these are very, very important. Staghorn calculus, putty kidney, then you have the VUR and you have PUJ obstruction, right? All right, let's go on to the next question now. And what do you think is the answer to this one? Correct. Absolutely right. So all of you are getting this right. What is the diagnosis that we are thinking of in this case? So what is given here is a young male presented with intermittent pain in the calf, and there is a painful ulcer at the big toe, and there is discolored skin. So what is the best initial investigation? So when there is intermittent pain in calf, that is intermittent claudication that we are talking about, and we are thinking about peripheral vascular disease, right? The arterial ischemia is what we are thinking about. We are not thinking about varicose veins here, right? We are varicose veins will not be just this big toe painful ulcer at the big toe surrounded by discolored skin. Varicose veins will have the varicose veins. This is the peripheral vascular disease, that is arterial ischemia that we are thinking about in this case. So, in this case, the first investigation that we would be doing is basically Doppler or a duplex ultrasound, right? Duplex or Doppler is what we would be doing here first. Why duplex or Doppler? Because it is non-invasive, right? It is cost effective. It is easily available, right? All these things basically puts this duplex or Doppler at the first investigation that we should do. Later on, for further evaluation, then we can do the CT angio and the DSA. The advantage with DSA, what is the advantage with DSA? Digital subtraction angiography is done by putting the catheter in the artery. So this is therapeutic as well. right? It is diagnostic and therapeutic as well. But the disadvantage is that it is an invasive investigation. We need to put the catheter into the artery. So that is invasive, right? So we should also be knowing, because in the recent exam, there was an image on identifying the investigation. So look at this image. A similar image was asked in the exam, and it was asked to identify the investigation. So this one is basically, you can see it's an ultrasound image showing the color, the blood flow in the vessel, and along with that, you are seeing a graph. This is what is called as a duplex scan or a spectral Doppler, a duplex scan or a spectral Doppler. So basically, where you see the spectrum of the blood flow, that is the graph of the blood flow, that is called as duplex or spectral Doppler, right? So uh, if the question is what is the best, then you go for DSA. It's a gold standard investigation in arterial disorders. All right. So what kind of flow are you seeing here? This is a triphasic flow that we are seeing. Remember that the limb arteries, the peripheral arteries normally should show this triphasic blood flow on the Doppler scan. Right, upward, downwards, and again coming upwards. This is the triphasic flow that we should see. Whenever there is narrowing, there is formation of collaterals. The collaterals, they are low resistance. They don't show the triphasic waveform. So remember that the normal limb arteries should show the triphasic waveform. Veins generally show the monophasic waveform. That's another question that is asked. Okay. So, uh, so right. The question here is, what is the best initial investigation in this case? It is the best initial investigation. So that is why the best initial investigation would be duplex or Doppler. If it's a gold standard investigation, then it would be DSA. Okay. Going on to the next question now. Let's go on to the next one. First, identify this investigation. This is the next probable question image in your exam. What do you think? What investigation is this image showing? For varicose veins, Susma, also for varicose veins, it is ultrasound. That's the investigation of choice. Absolutely right. This is DSA. Okay, this is digital subtraction angiography. So what do we see in this image is, this is a vessel with its various branches. Whenever in an angiogram, okay, whenever you have angiogram with the black color vessel, okay, if you have angiogram with black vessel, remember that it is DSA. CT angio, MR angio will never show the black vessels. It will always have the white vessels. So whenever you have an angiogram with the black vessel, always it's a DSA. But remember that the converse is not true. DSA can show the black vessel or it can show the vessel as white also. So remember the concept that under fluoroscopy, DSA is done under fluoroscopy. Any investigation which is done under fluoroscopy, it can give this black image or it can give the white image. Other examples of investigation done under fluoroscopy, like ERCP, is also done under fluoroscopy. The barium studies are also done under fluoroscopy, right? So remember that even in ERCP barium, you can get the black image or you can get the white image, right? Clear with everyone? Going on to the next question now. Again, one of the recently asked questions and a frequently repeated topic, the Mularian duct anomalies. What do you think would be the answer to this one? What do you think would be the answer to this one now? I see a lot of mixed answers here. So whether it's bicornuate uterus or it is a septate uterus, that is what we need to identify here. Now, first of all, for Mularian anomalies, okay, remember that for Mularian anomalies, HST is not a good investigation. Why HST is not a good investigation for Mularian anomalies? Because to identify the Mularian anomaly, that is uterine anomaly, we need to see the endometrium, right? and we need to see the outer surface of the uterus as well. How is HSG done? That is hysterosalpingogram. It is done by cannulating the cervix, then putting the contrast and taking the X-ray images. So when we are cannulating the cervix and pushing the contrast, it's only the endometrial cavity that we are seeing. We don't see the outer surface of the uterus in HSG. So in HSG, it is only the endometrial cavity which is seen. The outer surface is not seen. Therefore, it is not a very good investigation for uterine anomaly. The primary indication in practice to do HSG is to look for the tubal patency, right? To rule out the tubal cause of infertility. It is not done basically to identify the uterine anomaly. But for our exam, we should know that how to identify. So the most common image that they should be asking in the exam on HSG is a unicornuate uterus, because unicornuate uterus can be identified very well. It will be deviated to one side and it has one horn. The unicornuate uterus is also called as the banana uterus. Okay, it is also called as the banana uterus. Now, where the confusion comes is differentiation between septate and bicornuate uterus, because both of them will show two endometrial cavities. So the difference in septate and bicornuate uterus. The difference is, now what happens during the uterus development is there are two Mularian ducts which come in the midline and they fuse together, and then the septum is removed to form a single uterine cavity. Now in the bicornuate uterus, the problem is the fusion problem. The two Mularian ducts, they fuse in the below part, but the upper part are separate. So that means they are widely separated horns in the bicornuate uterus. So the angle that you have in between the two horns is more, right? It's going to be wide separation. In the septate uterus, the fusion has occurred, but the problem is that the septum is not removed. Okay, the septum is not removed. So what happens is the two cornu that you have, they are close together. That's the basic concept that we should know here. So bicornuate uterus, wide separation. Septate uterus, it is the close horns of the uterus that we have. But this is not foolproof again. There's an overlap that we have. It is said that septate में less than 70 होता है, bicornuate में more than 105 degree separation होता है. The middle part is basically the gray zone. So that is why we cannot differentiate very definitively on HSG septate from bicornuate. So what do we need to do next is ultrasound. We have 3D ultrasound, or even better than that is MRI. So if the question is, what is the best non-invasive investigation for Mularian anomaly, then it is MRI. If the question is overall the gold standard or the best investigation for Mularian anomaly, then it is going to be laparoscopy plus hysteroscopy, right? Why? Because on laparoscopy, you would see the outer surface. On hysteroscopy, you would see the inner, the endometrial cavity. So as I said, to identify a Mularian anomaly, we need to see both the inner cavity and the outer surface as well. So hystero plus lapro is the best. But the disadvantage again being it is invasive. MRI also shows the outer surface and the inner surface. So it is the best non-invasive investigation. Right. So now in this image, what do you see on HSG is, look at the two horns and look at the angle between them. They are close together, and that is why the answer in this particular image, this is going to be a septate uterus. Okay, this is going to be a septate uterus. Right. What will be the treatment for septate? We need to remove the septum. So the hysteroscopic removal of the septum is what we need to do. Okay. Now look at these images. Okay, look at this image. So this is the HSG image, right? Reiterating the point that investigations which are done under fluoroscopy, they can appear black or they can appear white. Here you are seeing the HSG, the contrast is appearing black. So what do we see is, again, there are two horns and there is this one lower part. This could be septate, this could be bicornuate. But look at the MRI image here. What are we seeing in the MRI? Look at the outer surface of the uterus and look at the endometrial cavities that we have. So there are two endometrial cavities, but the outer surface is smooth. So remember that smooth outer surface, S for S, smooth uterus is a septate uterus. That tells you that the fusion has occurred. If it's a smooth surface, that means the fusion has occurred, right? So remember that when it is smooth, it is septate. On the other hand, look at this image here. What do we have here is these are the two horns which are widely separated. Look at the angle, they are widely separated. When you do the MRI, look at the outer surface of the uterus, look at the inner surface, the endometrium of the uterus. Both of them are separate, right? Both of them are separate. You don't have one smooth surface. So this is bicornuate uterus. Remember, bicornuate uterus is bi outside, two outer surfaces, two inner surfaces. It is both two, the outer surface also and the inner surface also, right? Is this clear with everyone? I hope this is clear that how do you differentiate septate from bicornuate uterus, right? Very, very important, and you see the question on this very frequently in the exam. Now versus the didelphys uterus. What do you have in didelphys uterus, didelphys? Didelphys basically means there is no fusion at all, right? There is no fusion at all. So the entire uterus, the cervix, the upper vagina, they are different. It is completely separate uterus that we have. Okay, it's a completely separate uterus that we have. So we have two different cervix. So we need two cannulas basically in HSD to see that didelphys uterus, right? So everything is going to be two on in didelphys uterus. So there would be two cannula as well on HSD that you would see in didelphys uterus. Okay. So this is the concept of Mularian anomalies. Okay, this is the concept of Mularian anomalies. Now going on to the next question. Again, a question from gynecology. What do you think is the answer to this one? What do you think is the diagnosis in this case? Dharmendra, the arcuate uterus is like just a small fundal indentation, which is almost like a normal uterus. We don't need to do anything for arcuate. Right, this is the endometrial polyp. Again, this is a previously asked question in one of the exams. So what do we see here? What investigation is this? This is a transvaginal sonography, right? And what do we see here? This is the endometrium, the echogenic endometrium, and inside the endometrium there is something. This is the Doppler, TVS with the Doppler on. And what do we see is on the Doppler, this is the vascularity, that is the feeding vessel that is supplying the endometrial polyp, right? So most important point to be remembered here, that feeding vessel sign. Okay, so this is the question asked. Feeding vessel sign is indicative of endometrial polyp. The endometrial polyp grows within the endometrium. How do you differentiate it from a fibroid? Endometrial polyp versus the uterine fibroid. Endometrial polyp, because it is the proliferation of the glands, the endometrial glands, this is hyperechoic. Okay, this is hyperechoic. Versus fibroid, fibroid is the leiomyoma, that is the muscle. How does the muscle appear on ultrasound? Muscle appears hypoechoic on ultrasound, right? So remember that polyp is hyperechoic, fibroid is hypoechoic. What is the best investigation to differentiate the two? It is saline infusion sonography. How do we do that? So look at this image here. So this is the uterus on the transvaginal sonography. This is the fundus part, the body part, and the cervix part. We put the saline into the endometrial cavity, so that black color is the saline. So whatever is distended with saline, that is the endometrial cavity. So what do we see? That within the endometrial cavity, there is a lesion within the endometrial cavity. So this is the endometrial cavity distended with fluid, and this is the endometrial polyp, right? If it was a fibroid, it would be outside the endometrial cavity. It would not be within the endometrial cavity, right? So this one is endometrial polyp on saline infusion sonography, which is within the distended endometrial cavity, right? So remember that saline infusion sonography is a good investigation to differentiate polyp from fibroid. Okay, it's a good investigation to differentiate polyp from fibroid. Going on to the next one here. Okay, look at this image. Again, a transvaginal sonography. What do you think is this image showing? What do you think is this image showing? No. So what do we have here is, this is the one ovary that we have. This is the second ovary that we have. How do I know that this is an ovary? Because I see the black follicles within, right? There are those black follicles within the ovary. So what is happening is the two ovaries are coming together. Normally the ovaries should be separate, like one here, one here. When you have the two ovaries coming together in the midline and kissing each other. So you must have heard the terminology kissing ovaries, right? What brings the two ovaries together, kissing ovaries, is the adhesions. Adhesions are a feature of endometriosis. Okay, so it is endometriosis, which is where you are seeing the kissing ovaries. Remember that not every ovarian image on ultrasound is either PCOS or the ovarian hyperstimulation. Kissing ovaries are the feature of endometriosis. Here you are not seeing the peripheral follicles, right? If it was PCOS, you would see the peripheral follicles. If it was ovarian hyperstimulation, you would see the large cyst in the ovaries. You are not seeing anything of that sort here. So these are the kissing ovaries. When you see the ovaries in the POD kissing each other, that is kissing ovaries. You are not seeing endometrioma here or a chocolate cyst here as well, right? These are just the kissing ovaries. Another feature in endometriosis, yes, can be the chocolate cyst, that is endometrioma. And just remember an extra edge point here, that if you want to differentiate that the cyst in the ovary is a chocolate cyst or it's a regular hemorrhagic cyst, it can be differentiated on MRI by a sign which is called as T2 shading, right? The chocolate cyst shows the T2 shading, right? So why T2 shading? Because of the different stages of hemorrhages. With every menstrual cycle in the chocolate cyst, there is hemorrhage. So there is fresh hemorrhage, the Purana hemorrhage becomes chronic hemorrhage. So because of the different stages of hemorrhages, you would see T2 shading in the chocolate cyst, right? So this is, just a coincidence to have this chocolate cyst on the chocolate day. Going on to the next question. A 35-year-old female presented with fever, expectoration, and difficulty breathing. HRCT is done. What is the diagnosis? Yes, Leo, it means the different shades of the hemorrhage that we see on a T2 weighted image. Sayanthani, that's a good question. How do we differentiate between TAS and TVS? I'll tell you how to do that. Very good. So majority of you, almost all of you are right. The correct answer here is consolidation with air bronchogram. Right. This is again one of the recently asked questions in NEET PG exam. So what do you see in this CT image is, this is the lung which is normal. The normal lung appears black. This is the lung which is abnormal, which is white. Right. Normal lung contains air. Air is black on CT. So normal lung should be black. The white lung is the abnormal lung. Now, what do we see through this abnormal lung are this black bronchi. These are not the vessels. These are the bronchi. Look at this. These are the vessels. Vessels contain blood, are dense. They appear white. Bronchi contain air. They are black. So, these are the black bronchi containing air that we are seeing. So, this sign is called as air bronchogram. Now, air bronchogram is seen only in parenchymal pathologies. Okay, it is seen only in parenchymal pathologies. Why? Because the bronchi are present only in the lung parenchyma. So if this is the lung, this is the pleural space, the bronchi are only in the lung parenchyma. So to see the air bronchogram, we should have the lung which becomes white. The pleural space becoming white will not show the air bronchogram sign. So basically the air bronchogram is the white lung gives a good contrast to the black bronchi. So the prerequisite to see the air bronchogram is the lung becoming white. So any pathology where the lung becomes white, any cause of consolidation, be it pneumonia, right, be it pulmonary edema, be it hyaline membrane disease where you have bilateral whiteout lungs, be it pulmonary hemorrhage, all of them can show the air bronchogram sign. Mediastinal mass is outside the lung parenchyma, will not show air bronchogram. Pleural effusion outside the lung parenchyma will not show air bronchogram. Diaphragmatic hernia will have those air-filled bowel loops that you would see in the thoracic cavity, right? Is this clear with everyone? Yes. ARDS also can show the air bronchogram sign because ARDS is basically non-cardiogenic pulmonary edema, right? So pulmonary edema, be it ARDS as well, it can show the air bronchogram sign. ILD nahi, interstitial lung disease does not have that the white lung, the lung becoming white. That will not show the air bronchogram sign. Right, so it's the alveolar pathology that the alveoli becomes white that shows the air bronchogram. PAP, yes, Saurabh, PAP, pulmonary alveolar proteinosis, the lung becomes white, even that shows the air bronchogram sign. Okay, clear with everyone? So this is a recently asked question, recently asked image, so this is very, very important. Going on to the next one. So any radiology session is incomplete if I don't show you this image, because this is like the most expected image and a must know image. So what is the most effective way to treat this patient? It's resuscitation and exploratory laparotomy, because what are we seeing in this image is this is the air under diaphragm. Understand the concept, air is black on X-ray and CT. So this is the air under diaphragm. This is the diaphragm that we are seeing here. So air under diaphragm is suggestive of pneumoperitoneum, right? This is suggestive of pneumoperitoneum. So pneumoperitoneum, the most common cause is bowel perforation, right? You can have the history of peptic ulcer disease in the background, the peptic ulcer perforating leading to pneumoperitoneum. What is the first investigation that we do? X-ray. What is the best X-ray view? Remember, it is the chest X-ray erect, which is the best X-ray view for pneumoperitoneum. If not chest X-ray erect, then it is the left lateral decubitus with horizontal beam. Another important question for your exam. Remember, in pneumoperitoneum, we do left lateral decubitus with a horizontal beam of X-ray. The X-ray beam goes horizontal, not vertical. Always with decubitus, it is a horizontal beam of X-ray. Can you tell me a condition where in the chest X-ray we do lateral decubitus? Lateral decubitus chest X-ray is the most sensitive chest X-ray view for which condition? Absolutely right. Very good, Dr. Shravan. Majority of you are right. It is pleural effusion. Okay, pleural effusion. For pleural effusion, it is the lateral decubitus, which is the most sensitive chest X-ray view. It is the same side lateral decubitus. Ipsilateral lateral decubitus is what we should do for pleural effusion. Right? Clear with everyone? If I ask you that, what is the best investigation for pneumoperitoneum? What is the best investigation for pneumoperitoneum? The best investigation for any air containing pathology is CT scan. Okay, it is CT scan which is the best investigation for pneumoperitoneum. Okay, just quickly enumerating the signs in pneumoperitoneum. We have the Wriggler sign, we have the cupola sign, football sign, telltale triangle sign, the various ligament signs, right? And we have the inverted V sign, the Dodge cape sign. Remember, all these signs are important. INI-CET exam recently had a question on this, the sign in pneumoperitoneum. Okay. Going on to the next one. Again, an important question. So whenever you have a patient, okay, whenever you have a patient of RTA with low GCS and the NCCT brain being normal, we should always think about diffuse axonal injury. Okay, diffuse axonal injury. RTA patient, low GCS, CT scan normal, diffuse axonal injury. The best investigation for diffuse axonal injury is MRI. Okay, the most sensitive investigation is MRI. What sequence of MRI is the best sequence? It is susceptibility weighted imaging. Why susceptibility weighted imaging? Because in diffuse axonal injury, we want to look for punctate hemorrhages. For hemorrhage, susceptibility weighted imaging is the most sensitive sequence in MRI. So remember, it is SWI, which is the most sensitive sequence for hemorrhage. Now, let's have a look at this one. First, tell me that what do you think? Both these images, these are CT or these are MRI? These images are CT or MRI? What do you think? Right, absolutely correct. Both these images are MRI. Okay, both these images are MRI. Do not get confused by this white line outside. This is the scalp fat which is appearing white on MRI. Look at this black line just outside the brain parenchyma. That is the bone. Right, the black line, that is the bone. So this is MRI and this is a flare sequence where you see those hyper intense areas in the brain. This is the black area in the brain which looks like a T2 weighted image. This is basically T2 star image, a GRE image which shows this black areas which are called the areas of blooming and they represent hemorrhage. Okay, and they represent hemorrhage. So remember that these black areas are hemorrhage. These could also represent calcification. But in a patient of trauma, it is hemorrhage, which is what we think about. The investigation, the sequence that can help us differentiate hemorrhage from calcification is the SWI sequence, right? It can help us differentiate whether this blooming in GRE image is because of hemorrhage or is it because of calcification. We can differentiate on SWI, right? So DAI shows these punctate hemorrhages at the gray-white matter junction, right? This is the gray matter, the cortex. This is the white matter that we are seeing here. So the first stage of DAI has this gray-white matter junction, punctate hemorrhages, the petechial hemorrhages, right? Look at this one. What is the? This is a CT scan now, the white bone. And these white areas at the gray-white matter junction, these are the petechial hemorrhages, the punctate hemorrhages, which are suggestive of diffuse axonal injury. So remember that CT scan and diffuse axonal injury can be normal or it can show the punctate hemorrhages. It's not that always it's going to be normal. Is this clear with everyone? What is the first image MRI sequence? This is the flare MRI because it's all black. The water is black, the white matter is black, right? You see the internal capsule is black. So when you have all black, that is white matter, water also black, it's a flare MRI. Okay, it's a flare MRI, right? Let's go on to the next one now. What do you think would be the answer to this one? Which of the following best describes the IV iodinated contrast iodixanol? Right. So I see some confusion here. Let me tell you some quick tricks on the iodinated contrast media. Right. So classification of the contrast, the iodinated contrast media, ionic and non-ionic. Even in that, we have ionic monomer, we have ionic dimer, non-ionic monomer, non-ionic dimer. Now, remember that the ionic contrast, their names end in ATE, right? Carboxylate. Just say ATE ending, iothalamate. Then you have ditrizoate, metrizoate, the acid carboxylate ke jaise, ioxaglate. These are ionic contrast. So all the contrast media which end in ATE, that is basically that is going to be ionic contrast. The next one that we have is non-ionic contrast. They end in OL. Iohexol, iopamidol, ioversol, right? Then you have iodixanol or amide. These are non-ionic contrast. So remember the OL ending contrast are non-ionic. So based on this trick, if you go back to this, iodixanol, it's ending in OL. So this is going to be a non-ionic contrast, right? So I rule out the option, it's not ionic, it's not ionic. So option A and option C is ruled out. Remember that in the MCQ exams, ruling out is a very, very important trick that you should be using to score more. Now, whether it is non-ionic dimer or it is non-ionic monomer, even if I can identify that. So, remember that when I write iodixanol, okay, the iodixanol, the OL tells me that it is non-ionic, and the DI, iodixanol, the di helps me to remember that it's a non-ionic dimer. So this is a non-ionic dimer. So the correct answer is B. Even if I don't know whether it's iso-osmolar or it's low-osmolar, now from the option I know that it's a iso-osmolar contrast, right? It's a iso-osmolar contrast. So this is the iodixanol, which you can see here. It's a dimer and it's a non-ionic dimer. If you look at the ionic dimer, there is one example, that is ioxaglate. So ionic dimer, non-ionic dimer, they basically have one example, ioxaglate and iodixanol. So ioxaglate you can remember as ioxaglate, the Gl glue. Remember that ioxaglate is like glue is like 2. Okay, glue is like 2. 2 matlab it's a dimer. So the rest of the ATEs, they would become ionic monomer. Iodixanol is a non-ionic dimer. So the rest of the OLs would become non-ionic monomer. Okay, they would become non-ionic monomer. And this is the iso-osmolar contrast, that is iodixanol. Correct? Someone asked that what is the urographin? Urographin, remember, is urographin, gastrographin. This has been asked as the options in the previous exam. Urographin, gastrographin, these are basically brand names of ditrizoate, right? Ditrizoate, that means it's a ionic contrast. Okay, it's a ionic contrast. So ionic monomer contrast, you see that it's high osmolar. What is more safe for the kidney is high osmolar load or a low osmolar load? It's a low osmolar load, right? So now we do not prefer using this contrast. The most common that we use in the practice is iohexol, which is a low osmolar contrast. So the question asked was, in esophageal perforation, what contrast would you use? So remember that in esophageal perforation or any perforation, barium is contraindicated. Okay, barium is contraindicated. So instead of barium, we use the iodinated contrast. Even in iodinated contrast, iohexol will be preferred over gastrographin. Okay, it would be preferred over gastrographin. Dr. Nani Kumar, the MRI contrast is gadolinium. Okay, gadolinium is the contrast used in MRI because it's a paramagnetic substance. Okay? Going on to the next question now. What do you think is this one? I'll just write the options here. Is it A, B, C, or D? What do you think is the diagnosis here? Absolutely right. This is right pneumothorax. Do not confuse it with the right middle lobe pneumonia, just looking at this white part. So look at this radiograph. We see that this is the white area, but surrounding that is this entire black area. This black area is very jet black. There are no vascular markings that we are seeing. On the other hand, if you see in the other lung, look at these. These are the white vascular markings that we are seeing. So normal lung, the air in the normal lung will have these vascular markings. Pneumothorax is outside the lung, so it will not have the vascular markings. So remember that pneumothorax, pneumo matlab air matlab black, it's outside the lung, so it is black without the vascular markings. So this entire thing that we are seeing here, this is the right-sided pneumothorax. Immediate management in this patient would be the needle puncture, right? The first thing is to do the needle puncture, then is to put the ICD. Okay, then is to put the ICD, right? So this is pneumothorax. So look at these image. This is the M mode of ultrasound. You can get a question that identify this investigation. Is it A mode, is it B mode, M mode, or it's a Doppler? So when you see that in the ultrasound image, there is one line which is passing, and then you see this sort of image which is showing the movements basically. This is M mode. Remember, the M mode of ultrasound is to look for the movement of these structures. So normal lung shows the seashore sign. Pneumothorax shows the barcode or the stratosphere sign. In the seashore sign, look at the lower part. You would see this granular appearance. It's not the flat lines. In the barcode, like the barcode, you would see this flat lines in the below part. It is the lower part of the image that you need to differentiate. Upar ka part is going to be the same, right? So remember that seashore sign is normal. Barcode or stratosphere sign, that means the multiple horizontal lines, that is seen with pneumothorax, which is included in evaluation in E-FAST. Extended FAST includes the evaluation of thoracic cavity also now. Okay. So seashore is normal, barcode or stratosphere is pneumothorax. Next question. So infertility patient undergoing under the treatment for IVF now has history of acute pain in the abdomen. What is the diagnosis? The history itself is enough in this case to make the diagnosis in this case. Infertility patient, acute pain in abdomen. This is going to be ovarian hyperstimulation. Because an infertility patient, we hyperstimulate the ovaries by giving clomiphene citrate, right? So, look at this image here. What do we have is, again, this is the ovary that we are seeing, and you are seeing those multiple large follicles appearing like cysts in both the ovaries, right? So the point to differentiate ovarian hyperstimulation syndrome from PCOS. In PCOS, you have those peripheral small follicles, right? None of them is the dominant follicle. The follicles are less than 10 mm in size, and you have the increase in central stroma, right? Because of the increased androgens, there is increase in central stroma. While in the ovarian hyperstimulation, there are those large follicles like the cyst in the ovary without the increase in the central stroma. Sayanthani, for pneumothorax, it is the lung point sign, which is the most specific sign for pneumothorax. Okay. So another pathology which can look very similar to the ovarian hyperstimulation syndrome is the theca lutein cyst. Both of them can look similar, right? Large follicles without the increase in the central stroma. But the difference is, where do you see the theca lutein cyst? Very good, Vikram. That is going to be in a case of molar pregnancy, right? So this patient, the history would be beta HCG positive or high beta HCG levels. That is what we see with molar pregnancy. And what is the treatment for What is the treatment for this theca lutein cyst? Nothing. You don't need to do anything. Once you remove the molar pregnancy, suction evacuation for the molar pregnancy, the beta HCG goes down. So the ovarian stimulation that was happening because of beta HCG also goes away. So in majority of the cases, there is spontaneous resolution. Okay, in majority of the cases, there is spontaneous resolution. Okay, so remember that the both of them can look similar, but the history will help you differentiate the two. Look at this image and tell me, what do you think is this ovary showing? So this is the ovary with the peripheral follicles because of the increased central stroma, right? So this is the necklace sign or the string of pearls sign. Okay, this is the necklace or the string of pearls sign that we see in PCOS, right? So now this is PCOS. We use Rotterdam's criteria for diagnosing PCOS. Can the ovary look normal in PCOS? Ovary can appear normal in PCOS. Is this true or is this false? So you are suspecting PCOS, but the ovary is not showing the necklace sign. Can it still be Can it still be PCOS? Yes, right. Why? Because in the Rotterdam criteria that we use for PCOS, it's only if 2 out of 3 criteria suffice, they are meeting the criteria, then we make a diagnosis of PCOS. That is the clinical features, right? Then you have the lab features, and then you have the ultrasound features. So even if clinical and lab features are suggestive of PCOS, we still make a diagnosis of PCOS, right? Ultrasound can be normal. Ultrasound can be normal. Okay. What do you think is this image showing? What do you think is this image showing here? Very good. Yes, Karima, that is the molar pregnancy, the snowstorm appearance. So this is the uterus that we are seeing. And in the endometrial cavity, we have this multiple cystic appearance. Why do I call it cyst? Because it is black. Fluid is black. So this is the vesicle-like appearance. This is the V mole or the H mole, which is showing this snowstorm appearance, which is seen in a case of complete molar pregnancy. Okay, this is the snowstorm appearance, which is seen in complete molar pregnancy. And this is what can show the theca lutein cyst. Okay, you can see the theca lutein cyst in ovary in these cases. The treatment for this complete molar pregnancy would be suction and evacuation. Okay, that would be suction and evacuation. Okay, going on to the next question. This is a previously asked question again. This has been asked in one of the previous NEET PG exam. The sign seen on ultrasound when the common femoral vein meets the great saphenous vein and the femoral artery at the SFJ is the correct. That is the Mickey Mouse sign. So look at the image here for the Mickey Mouse sign. So what do we have is the larger one is the vein. That is the common femoral vein. Vein के बाजू में we have the artery. Okay, that's the femoral artery. And we have the great saphenous vein which drains into the femoral vein. So what do we have in the Mickey Mouse is basically like this. So the bada wala is the femoral vein. Then you have the femoral artery and you have the great saphenous vein draining into the femoral vein. So that gives the Mickey Mouse sign. Okay, that is the Mickey Mouse sign that is seen at the saphenofemoral junction. Anywhere else we see the Mickey Mouse sign? Remember, the Mickey Mouse sign is also seen at the porta, where you have the portal vein, then you have the hepatic artery, and you have the CBD. So the three structures at the porta also show the Mickey Mouse sign. Okay, even at the porta, we see the Mickey Mouse sign. Okay. So just a previous year question, and that's why it is important to be known. Next one. Interesting question. Look at the image. Tell me, what do you think is the diagnosis in this case? Yes, very good. This is scleroderma. Now, why do you call it scleroderma? What is the major clue here in the CT image to tell you that this is scleroderma? What is this structure that we are seeing here? This dilated structure here. What is this one? This is not the trachea. Okay, this is not the trachea. Behind the heart, posterior mediastinum, what we are seeing here, this is the esophagus. Right, so the major clue here in the CT image, this is the dilated esophagus. And where do you have esophageal enlargement in which of these conditions? Scleroderma, right? That is esophageal dysmotility. So dilated esophagus with this appearance here, that is the honeycombing like appearance. There are these multiple air fill like cysts stacked one upon the other, suggestive of ILD pattern, right? So the interstitial lung disease with dilated esophagus, we should think about scleroderma. What are the antibodies that are going to be positive in this case? Diffuse scleroderma and limited scleroderma, right? The CREST syndrome. So remember, scleroderma is anti-SCL70. Sclero, SCL. It is anti-SCL70. When it is the CREST syndrome, C for C, it is the anti-centromere antibody that we have in the CREST, right? That's there in the CREST. Okay. This is not rheumatoid arthritis because the dilated esophagus is the clue here to help you to identify key this is scleroderma. Esophageal dysmotility with is a feature of scleroderma. So when you have ILD pattern with a dilated esophagus, think of scleroderma. Okay, think of scleroderma, right? Going on to the next one. What would be the barium enema findings in this given case? What would be the barium enema finding in the given case? Yes, CREST is limited scleroderma. Right. So this is going to be, let's have a look at where do you see these various signs. Where do you see the sawtooth appearance in barium enema? The sawtooth appearance is like this. So the sawtooth appearance is seen with colonic diverticulosis. Where do you see the apple core? Apple core is the narrowing, the irregular narrowing. Core, COR, is seen in CAR, that is, it is seen in carcinoma colon. Okay, that is seen in carcinoma colon. Where do you see the coiled spring appearance? The coiled spring is the barium going in between the intersusceptum and the intersuscipiens. The space that we have in between that, this is seen in intersusception. Where do we have the bird of prey sign in the barium enema? The bird of prey is like this. So the barium going up and suddenly it gets cut off here, and beyond that point is the sigmoid volvulus. So the bird of prey sign on the barium enema is seen in sigmoid volvulus. So now you know the signs and look at the CT image. What is the CT image showing? The CT image is showing this inner circle and an outer circle, that is the target sign. Okay, the CT scan is showing the target sign, the intersusceptum and the intersuscipiens. So this is suggestive of intersusception, right? So the barium enema would show a coiled spring sign. Okay, the barium enema would show a coiled spring sign. And in intersusception, remember the history would be of the red currant jelly stools. Okay, that's a very important history, red currant jelly stools. And the immediate management would be pneumatic or air reduction. Pneumatic or hydrostatic reduction is what we can do. Now, if the question is, what is the investigation of choice in intersusception? Intersusception is common in a child in the weaning age. When there is lymphoid, the Peyer's patches get hyperplastic. So we prefer an investigation which has no radiation exposure, that is ultrasound, because ultrasound has no radiation. It can show this target or donut sign very well. So ultrasound is the investigation of choice. Yes, another recently asked question. Which vaccine can have this complication of interception? Remember, related to the intestine, that is rotavirus. Okay, rotavirus vaccine can have this complication of interception. Okay? Management is going to be the pneumatic or the air reduction. We put the air through the rectum so that the air pressure removes the interceptum. All right. So this is the target or the donut sign. Look at this barium images. Both of these have been asked in the exam. First image is showing this coiled spring sign. The second image, this is the barium. This is the barium going up and it is forming a claw. So the barium goes up at the site of interception. It forms a claw around the interceptum. Right. So the other sign in barium enema is claw sign. And the first one is the coil spring sign. So these are the two signs that we see in interception on barium enema. The claw sign and the coiled spring sign. Both of these have been asked in the exam and these are important. Okay. Going on to the next one. What do you think is the diagnosis in this case? Is it pulmonary embolism, aortic thrombosis, Stanford A aortic dissection or Stanford B aortic dissection? Right, majority of you are answering it correctly. This is the Stanford A aortic dissection. Because look at the image here. What is the investigation? The white bones, this is CT scan. The contrast in the aorta, this is a contrast enhanced CT. Let us identify the structures here. What is this structure here anatomically? What is this structure here? So remember that we have the structures in the mediastinum, the three vessels arranged from right to left. It is SAAP, S-A-A-P. So this is the superior vena cava, the ascending aorta, and then there is this pulmonary artery and the pulmonary artery here. So what are we seeing in this image is that this image is showing this dilated ascending aorta with this intimal flap. That black line is the flap, the intimal tear, which has divided the aorta into two lumen, right? So the aorta has got dissected, has got divided into two. So that is why this is aortic dissection with the intimal flap. Is the ascending aorta involved or is it the descending aorta also involved? Where is the descending aorta? This is the vertebra. To the left of the vertebra, this is the descending aorta, and the descending aorta is also showing this intimal flap. So both are involved. Aortic dissection involving the ascending aorta plus the descending aorta. Now, so we use Stanford classification for aortic dissection whenever the ascending aorta is involved. Remember A for A, it is Stanford A, right? Stanford A is when the ascending aorta is involved. So this is Stanford A aortic dissection. Next question is what would be the management? Whenever it's the ascending aorta involved, we are more worried about it. The prognosis is worse. So we need to do surgery in that case. Surgical management is what needs to be done. When it is Stanford B, that means without the involvement of ascending aorta, if the patient is stable, we can give for B, we can give beta blockers, right? Esmolol can be given. Beta blockers are given if it is Stanford B. If I ask you what DBakey classification is this one, you have DBakey classification as well. Alpha summers, the clipping and coiling is done for aneurysm, right? This is dissection. What DBakey classification is this patient? DBakey 1, DBakey 2 or DBakey 3? So let's have a look at this classification of aortic dissection. Stanford is just A and B. Whenever the ascending aorta is involved, it is Stanford A, right? When the ascending aorta is not involved, it is Stanford B. DBakey has 1, 2, 3. So DBakey 1 is the most severe, where the ascending aorta plus the descending aorta is involved. So ascending aorta plus the descending aorta. So most severe 1. Then you have removed the descending aorta, only the ascending aorta, that is DeBakey 2, right? And then you have only the descending aorta involved, can go to the abdominal aorta as well, that is type 3. So remember DeBakey 1, 2, 3. It is most severe to less severe, ascending aorta plus descending aorta, ascending aorta, and then you have the descending aorta. Okay, then it's the descending aorta. So this is both ascending aorta plus the descending aorta. So this is going to be DeBakey type 1. Okay, this is going to be DeBakey type 1 aortic dissection. If I ask you that what is the most important risk factor for developing aortic dissection, this was like a NEET PG 21 question. A clinical question was asked. Most important risk factor is hypertension. It is not atherosclerosis. Atherosclerosis leads to aneurysm, weak wall dilatation. Hypertension, the blood flowing with high pressure, leads to intimal tear, that leads to aortic dissection. So in a case of aortic dissection, you will have a patient, hypertensive patient, presenting with acute chest pain, tearing sort of chest pain going to the back. It can be unequal blood pressures in the upper limb, because if one subclavian artery is involved, that can have a low blood pressure on that side. So this was a clinical scenario given, a 45-year-old male patient with acute chest pain, unequal blood pressures in the upper limb. What is the investigation to confirm the diagnosis? What is the investigation to confirm the diagnosis? So if the patient is stable, that means there's no hypotension, then we can take the patient to CT scan and we can do CT angio. If the patient is unstable, that means we do not have time, like we cannot take the patient to CT scan room. So we need to do bedside investigation. Bedside is ultrasound. What ultrasound we do? Transesophageal echocardiography. Echo is basically sound, that is ultrasound. So remember that if it is an unstable patient, then it is TEE. If it is a stable patient, then we do CT angio in that case. Okay, then we do CT angio in that case. Right. Going on to the next question now. What do you think is this one? Identify the structure labeled 3. And if I can zoom in this image, where is the structure labeled 3? This is the structure labeled 3 here. Okay. So now have a look at the image and now tell me what is the answer to this one. Yes, Anukriti, the PDF would be available post session on the Telegram group, on my Telegram group, and also on the PrepLadder's Telegram group. Right, you can join the Telegram group, Dr. Nikita's Rat Synapse, and also the PrepLadder Telegram group. Why do I see this confusion here? Majority of you answer it is D, internal carotid artery. The structure which is asked here is this one. Okay, this is the vessel which is asked. Always try to trace the structure. Yes, Manisha, correct. Look at this. First of all, identify the investigation. You are seeing the vessels here. So this is angio. You are not seeing the white bone. This is not a CT angio. You are seeing the vessels on both the sides. So it's not a DSA. DSA is one side at one time, one vessel at one time. So this is MR angio, where you see the white vessels without the white bone. Now trace this vessel which is asked. Trace this vessel. Try to trace this vessel up. Try to trace this vessel up. What is this vessel doing? It is joining with the other side vessel and forming a single vessel. So what vessel is that? That is vertebral artery. Okay, this is the vertebral artery on one side. This is the vertebral artery on other side, joining to form the basilar artery, which is the internal carotid artery here. Right, the other artery which is coming here, and then going up, supplying the brain. This is the internal carotid artery, giving the middle cerebral artery. From the common carotid, the other vessel that we have, that is the external carotid artery. Look at this one. So this is the common carotid artery, right? The vessel which is going up to the brain, that is going to be internal carotid. The vessel which is Upwards only, that is going to be the, which is not going to the brain, that's going to be the external carotid artery. Okay, that's going to be the external carotid artery, right? What is this artery here basically? Anyone can identify the structure labeled 1? What is the structure labeled 1 here? What is the structure labeled 1 here? So this is 11 is the arch of aorta. From that, coming the first vessel coming from the arch of aorta. Very good, Dr. Sarika. That's the brachiocephalic trunk. Remember the branches from the arch of aorta from right to left. It is B, C, S. That is the brachiocephalic trunk, the left common carotid, and the left subclavian artery. Okay. So that's the left common carotid going up. This is the left subclavian artery. Brachiocephalic, brachio gives the subclavian artery. So number 2 is the right subclavian artery and it gives the right common carotid artery, right? So you have the right subclavian and the right common carotid artery. From where is this subclavian artery, the vertebral artery arising? The vertebral artery comes from the subclavian artery. The first part of the subclavian artery gives the vertebral artery. It's a branch of subclavian artery, right? So these are the various vessels that you are seeing here. The structure labeled 3 here is the vertebral artery, which is joining with the other vertebral artery to form the basilar artery. Okay, to form the basilar artery, right? Next question here. Kohler's disease affects which of the following bones? 1, 2, 3, 4, 5. Kohler's disease affects which of the following bone? Is it 3? Is it 4? Majority of you are right, correct. Remember that Kohler's, when I write Kohler's, it is rhyming with navicular. Okay, Kohler is rhyming with navicular. So Kohler's affects navicular. And how do I identify the navicular bone? By this boat shape bone here. Navicular, remember navicular is like a nav. That means it's like a boat. So this boat shaped bone here, that is the navicular. The bone labeled 3 here. Okay, the bone labeled 3 here. Behind the navicular, that is the talus. Okay, that's the talus. Then you have again navicular. And this bone here on the lateral side, this is calcaneum. Okay, that is calcaneum there. And in front of the calcaneum, on the lateral side, the bone that we have there, that is the cuboid. Okay, that's the cuboid bone there. Okay, so this is the talus navicular calcaneum. You have this talocalcaneo-navicular joint here. Let's just integrate with some anatomy here. Tell me this talocalcaneo-navicular joint is what kind of joint? The TCN, talocalcaneo-navicular, is what kind of joint? It is a ball and socket type of synovial joint. This calcaneocuboid joint, right? This joint, the CC joint, is a saddle joint. Calcaneocuboid joint is the saddle joint. Talocalcaneo-navicular is a ball and socket type of joint. So the correct answer here is 4. Okay, the correct answer here is 4. Going to the next question here, what do you think would be the answer to this one? A 50-year-old male presents with bone pain. Based on the radiograph, what is the diagnosis? Absolutely right. This is Paget's. Okay, this is Paget's disease. Can someone tell me why is this Paget's disease? Very good. Very good, Divya. So what are we seeing that in this femur? Okay, this is the femur that we are seeing here. In the femur, we are seeing this lytic lesion, which is going towards the diaphysis like a blade of grass or the candle flame sign, right? So candle flame sign or the blade of grass sign, when we have the sign like this, lytic lesion, this is Paget's disease. Remember, Paget's is both lytic and blastic. Okay, it has both features. It presents in the elderly patient, right? This is pages. Next, if I ask you that, what will be increased in this patient? Another important question. Will there be increase in calcium, phosphorus, or will there be increase in alkaline phosphatase, or all of the above? What will increase in pages? Absolutely right. Remember that pages has increase in alkaline phosphatase only. Okay, that is markedly elevated alkaline phosphatase in a patient of pages. What is the vertebral appearance? It is picture frame vertebra. P for P. Pages has picture frame vertebra. In the skull, it gives the cotton wool skull. Right? It gives the cotton wool skull. It can also give osteoporosis, circumscripta, and there is tam o'shanter hat sign, right? The tam o'shanter sign. All this is what we see with pages. Okay, all this is what we see with pages, right? It can give the ivory vertebra as well. Ivory vertebra, picture frame vertebra, all these signs are seen with pages. Okay, going on to the next question here. Very important, has been asked in the recent FMG exam. The history is very important here. Right. The most important clue here is bilateral lymphadenopathy was seen. Whenever you see bilateral lymphadenopathy, bilateral hilar lymphadenopathy, always think of sarcoidosis. So in sarcoidosis, we have bilateral hilar lymphadenopathy. We can also have the right paratracheal lymph node that gives the 1, 2, 3 sign. Okay, that gives the 1, 2, 3 sign or the Garland sign on chest radiograph. These lymph nodes, correct, can show the eggshell calcification. Okay, the lymph nodes can also show the eggshell calcification. What do you see here in this radiograph? These are the bulky, the round lymph nodes that we are seeing here. Bilateral hilar lymph nodes is what we are seeing here. Sarcoidosis. What is the feature on CT scan? HRCT, what does it show? What does it show on HRCT? So on HRCT, this is the fissure and you see the nodularity, the nodules along the fissures. Okay, the nodules along the fissures, the subpleural nodules, because sarcoidosis has, the lymphatic involvement. So perilymphatic nodules, which is perifissural nodules, are the feature that we see in sarcoidosis. There can be nodules with multiple small nodules alongside that gives the galaxy sign in sarcoidosis. So we have perifissural nodules and we have perilymphatic nodules. Galaxy sign is what we see in sarcoidosis. The gallium scan can show the panda sign, right? It can show the panda sign and the lambda sign. The gallium scan can show the panda sign and the lambda sign. Pawnbroker sign is the same, right? The 1, 2, 3 Garland sign or the pawnbroker sign, also it is called as pawnbroker sign. Okay. Right. I believe this is the last question that we have to be discussed. X-ray shoulder in the 60-year-old male is suggestive of which of the following? Very good. This is the posterior shoulder dislocation. Why do you call it the posterior shoulder dislocation? Because of the light bulb sign. Okay, because of the light bulb sign. So what do you see normally is in the normal shoulder radiograph, there should be this overlap of the glenoid and the humerus head. Right, there should be this overlapping part that we should see. Now, when you don't see the overlap, okay, the humerus head is rotated and it appears like a light bulb, there is no overlap, then it is called as the light bulb sign. Okay, this is the light bulb sign. Normally, there should be this overlap. Okay, so this is the light bulb sign which is seen with posterior dislocation of the shoulder. Remember this point. Okay, so this is the posterior shoulder dislocation. So normal half moon overlap this is the normal one, and this is the light bulb sign that we see in posterior dislocation, right? And this has been asked in the recent years FMG exam. Hip dislocation. Tell me what is the image A and what is the image B, which is anterior dislocation and which is posterior dislocation of the hip. Image A is anterior or posterior? Absolutely right. So, what do we see here? Look at the position of the femur. See, first of all, this is the acetabulum. The femur is out. It's not articulated with acetabulum, so dislocation. The position of the femur is outwards. That means this is abducted position. So, when you have Faber, right? Faber is anterior dislocation, abducted. When you have, this is again the dislocation, but the femur is going towards the midline, right? It's going towards the midline. That means it is adduction. So remember that father, adducted position, father is paternal. So remember that father paternal, this is posterior dislocation of the hip. So when you have adducted femur, it is father, that is PDH, posterior dislocation. And when it is abducted, it is anterior dislocation. Which is more common in the hip? It is posterior dislocation, which is more common, and it is seen with dashboard injury, right? The dashboard injury leads to the femur going behind. So dashboard injury gives the posterior dislocation of the hip. And again, it's an expected image in your exam. This has been asked recently, right? So that was about the today's radiology marathon for your NEET PG exam. We have tried to include all the recently asked images and the most expected images that have been asked in the recent years. Make sure you identify all of them. Yes, Sagla Charan, your query that TAS versus TVS, you differentiate by the image. In TVS, you would see this round part above. In TAS, the image would be like this. Okay, try to just see some images, Google out some images. TAS, in TVS, the probe section you would see like this. In TAS, it would be like a quadrant like this. It would not have a circular part. Okay, so thank you so much, everyone, and thank you for all the love. Keep showering that. And goodbye, take care, and keep studying, keep revising, and keep winning. All the best for your upcoming exams. Thank you.